Welcome to today's Explainer. We are building your high-yield clinical toolkit for recognizing and managing three absolutely critical pediatric emergencies. You know, when you're dealing with pediatric patients, things can literally change in the blink of an eye. Having a structured, immediate response plan, it isn't just helpful, it's absolutely vital. So, let's dive right in. Our roadmap today covers three distinct clinical scenarios. First, respiratory emergencies and choking. Second, brief resolved unexplained events, or BRUE. And third, sudden unexpected infant death, or SUID.
All right, let's jump straight into Section 1, Respiratory Emergencies and Choking.
So, pediatric airways are significantly smaller than adult ones, right? And kids just have a lower physiologic reserve. Because of this, they can decompensate incredibly fast when their airway is compromised. You really have to train your brain to catch the early signs of distress, things like a racing heart, restlessness, rapid breathing, or breaking out in a sweat. When a child is in early distress, they're working super hard to breathe, but they're still managing to exchange gas. But if you start seeing late signs, things like bradypnea, where their breathing actually slows down, or cyanosis or stupor, that means severe advanced hypoxia is already happening. You literally cannot wait for these late signs to act, because by then, the child is right on the brink of respiratory failure. Okay, let's say you suspect a child is choking. Your absolute first assessment step is just answering a simple question. Can the child cough, cry, speak, or breathe? If they can still forcefully cough or cry out, their airway is only partially obstructed. This is a critical moment. Don't intervene physically just yet. Your job here is to encourage them to keep coughing to clear it themselves, while you stand by, completely ready to jump in if things go south. However, the whole game changes instantly if the obstruction becomes severe. If you see the universal choking sign, clutching the neck, or if they can't speak, or you hear high-pitched wheezing, or worse, absolutely no sound at all and you see cyanosis setting in, that is a complete obstruction. There is no air moving. This is a massive safety alert requiring immediate, life-saving intervention. You've got to call 911 right away. When you do step in for severe obstruction, we have to follow the age-based guidelines. You obviously can't treat a tiny infant the same way you treat a teenager. Infants under 1 year old need a combination of back blows and chest thrusts. On the flip side, older children and adolescents require abdominal thrusts to force the air up and dislodge that object. And before we move on from airways, we have to bust a really dangerous myth right here and now. Never, ever use your finger to blindly sweep a child's mouth. I know it's incredibly tempting when you're in a panic, but a blind finger sweep can so easily push the object even further down the throat, making the obstruction worse and potentially causing mechanical injury. The rule is simple. Only remove an object if you can clearly see it and easily grab it. Moving right along to Section 2, Brief Resolved Unexplained Events, commonly known as BRUE. Now, this used to be called ALTE, or Apparent Life-Threatening Event, but the terminology was updated to BRUE to be way more clinically precise. A BRUE is an absolutely terrifying event for a caregiver. It's a sudden episode where an infant stops breathing, turns pale or blue, goes totally limp, or loses responsiveness. But here is the major defining characteristic. By the time you're actually evaluating the infant, the event has fully resolved and they've completely returned to their baseline. Because the infant is back to baseline, your physical exam is probably going to be totally normal. They might just look like a happy, perfectly healthy baby sitting there on the exam table. But you have to stay vigilant. A normal exam does not mean you're in the clear. The differential diagnosis for a BRUE is massively broad. It could be a GI issue like reflux, an infection, a neurologic issue like a seizure, or even a metabolic disorder. Since the potential causes are all over the map, you'll see a lot of different tests ordered during the workup. Blood cultures, viral studies, EKGs. But this actually brings up a really surprising question you'll see a lot in clinical practice. Why on earth would a provider order a urinalysis for a baby who just had a breathing and color change event? Well, the answer is that infant UTIs are incredibly sneaky. It's wild, but in really young children, a urinary tract infection often completely bypasses those classic urinary symptoms we look for in adults. Instead, the infection can present entirely as a systemic, nonspecific event, like a BRUE. So anticipating a urinalysis in this workup is an absolute must-know clinical pearl. It's the perfect example of why we cast such a wide diagnostic net, even when the kid looks totally fine in the moment. All right, our final chapter, Section 3, sudden unexpected infant death, or SUID.
For this section, our toolkit pivots entirely toward empathy, family support, and rigorous, uncompromising prevention. Sudden unexpected infant death, which includes what we used to call SIDS, can happen anytime during the first year of life, but the peak risk window, that's distinctly between 1 and 6 months of age. Why that specific window? Well, that's the exact developmental period when an infant's protective reflexes and arousal mechanisms are still maturing. That makes them exceptionally vulnerable to environmental stressors while they're sleeping. Identifying the risk factors is step 1 for prevention. Now, some factors, like prematurity or low birth weight, are historical. We can't change them. But look at the rest of these. Maternal or secondhand smoke exposure, co-sleeping with an adult, using non-standard sleep surfaces, or putting the baby to sleep on their stomach or side, these are entirely environmental. And that means they are modifiable. We can literally change the outcome through really good caregiver education. Which brings us right to the definitive safe sleep checklist. Babies have to be placed on their backs for every single sleep. They need a firm, tight-fitting mattress in a proper crib. There should be absolutely no soft bedding, no pillows, no quilts, no stuffed animals. The head has to stay uncovered to avoid overheating. And finally, caregivers should absolutely room share, meaning the crib is in the parent's room. But they must never, ever bed share. Honestly, tailoring this conversation to help a family overcome their specific barriers, like cultural norms or maybe lacking a crib, is how you truly change behavior. Oh, and one quick point of clarification before we finish, because this confuses a lot of parents. Sleep positioning is strictly back to sleep to prevent SUID, full stop. But tummy time, we highly encourage tummy time because it's essential for motor development. The rule is just really strict. Tummy time is only for when the infant is fully awake and actively supervised. As long as you maintain that boundary, the two concepts don't contradict each other at all. So, wrapping up our explainer today, I want to leave you with this final thought. We've gone from the pure adrenaline of clearing an obstructed airway to the investigative mystery of a BRUE, all the way to the deeply empathetic education needed to prevent SUID. Recognizing these specific scenarios doesn't just help you ace an exam, it literally empowers you to save lives and protect families when they are at their absolute most vulnerable. So, how will you apply this toolkit in your next clinical encounter? Thanks so much for learning with me today, and keep that curiosity sharp.